We are live.
So good evening, friends and members of AIOS. As you are aware, AIOS ARC has been doing various webinars on varied subjects of interest to common ophthalmologists. As you have seen, ophthalmology has seen a sea change in the concepts of how we look at the disease, and every new subspecialty in itself has come in a big way, and we need to refresh our own memories. Maybe we need to refresh the way we look at a disease as well as the surgical techniques. But as we are aware, we have moved a lot into the cataract surgery. We have moved into flags. We have moved into phacoemulsification. But even now, SICS is one of the most happening surgery in our country as well as all across the world. And so it was time for us to revise this particular subspecialty. In this episode, we will be having the topics basically which are designed for comprehensive ophthalmologists for their understanding and to reiterate the importance of this wonderful technique. I would take my special thanks goes to Dr. Parikshit Gokte and Dr. Deepak Mishra, our own ARC member from Center, for crafting such a wonderful program. And of course, about the Saransh, since we have taken over the ARC, Saransh has been put into our every webinar. So what is Saransh? It is about the gist of the articles which have been presented in last 2 years about the subspecialty in which we are discussing that particular webinar. So today's Saransh would be presented by Dr. Parikshit Gokte. So without much ado, now let me hand over the further proceedings to moderator Dr. Satanshu Mathur and Dr. Deepak Mishra. Over to you, Dr. Deepak.
Thank you, sir. As we all know, this webinar has been planned on the SICS for all. And the expert panel, we have the 4 eminent expert panels for the today webinar. Padam Shri Professor T.P. Lahane, sir, Professor K.P.S. Malik, sir, Professor Banu Naik, sir, and Dr. Amulya Sahu, sir. Apart from me, Dr. Satanshu Mathur is the another moderator, and we have a lot of experts and mentors who can give their viewpoints on the discussion of after each and every topic. These includes Professor Ragini ma'am, Dr. Arundhati, Dr. Jagannath Buramani sir, Dr. Prasanna, Professor Arvind Maurya, Dr. Kamaljeet Singh, Professor Ruchi Goyal ma'am, Professor Purvi Bhagat, and Dr. Hanumant Bhosle. They will discuss after each topic and give us some feedback and other thing, or what's are lacking in the topic, or how we can understand more on this topic. And then we have our own Dr. Parikshit Gotke sir, who will presenting us the Saransh, means whatever we have covered in that and what is in the literature. So sir will discuss about the whole literature search, which gives us some scientific value on the SICS. Then we have lot of speakers. We go one by one with all the speakers and will invite everyone. With this, Parikshit sir, we can start our first debate.
Yes, so we have Dr. Lobsang Satin and Dr. Pranav Kodial debating against each other. Dr. Lobsang first. Dr. Lobsang is from Arunachal, works for the Ramakrishna Mission, and has done yeoman work on the Indian-Tibetan border. So we'll look forward to hearing from Dr. Lobsang.
Thank you so much, sir. At the very outset, I would like to thank AIOS and ARC for this wonderful webinar and making me a part of this webinar. So I will be presenting on SICS for masters. Is it visible now?
Yes, sir.
Yes, sir.
Okay.
Not on slideshow mode.
Okay. So I'll be speaking on SICS for masters. So we know that the goal of modern cataract surgery is rapid patient mobilization, be it in terms of physical or visual, and surgery should have minimal surgically related complications and should have better unaided vision postoperatively. So if you see, phaco is the gold standard of treatment for cataract surgery nowadays worldwide. But SICS was found to be almost as good as phacoemulsification after assessing visual outcome, vision-related quality of life, and the cost. So if you compare SICS with phaco, the wound size in SICS would be 5 to 7 millimeters, and phaco would be sub 3 mm, but both would be self-sealing. There is a vast difference in the cost because phaco is costly because of the instrumentation and the equipment that is required in phaco. And then if you see the learning curve, you have a shorter learning curve in SICS, whereas in phaco you have a longer learning curve. And you need a very good hand-foot coordination for phaco, whereas you can do SICS with single hand. Safety profile, if you see, phaco has higher rate of complications as compared to SICS, and both have good recovery rate, whereas phaco, because of the smaller incision size, has a faster healing rate. And phaco is not ideal for hard and luminescence cataract, whereas for such cataracts, even for subluxated cataract, SICS could be the ideal surgery. So we can say that SICS is the king of the masses because it's easy to perform and it's reliable. It solves a global health problem of cataract backlog. It has a good value in terms of cost, and it's adaptable according to the ocular tissue. And also it's innovative because you have a lot of variations in SICS nowadays. So SICS is good because it's applicable on all types of cataracts. Then even with CCC or even with can opener also you can do SICS. And if there is a corneal opacity or a large pterygium also, you can perform SICS in terms of poor visibility. And it is the ideal surgery for high volume cataract surgery. And it has wider applicability and more economically viable than phaco. And it's a bailout surgery. Supposing if you are stuck up in a complicated phaco, then you convert to SICS. So it offers advantage under challenging cases where an excellent outcome can be achieved without complications. It serves as a stepping stone for performing good phacoemulsification surgeries because if you want to learn phaco, then you have to be a good SICS surgeon. And SICS is more of a skill-based surgery that improves the surgeon's tissue handling. So the results of meta-analysis with SICS and phaco has shown that both are comparable in terms of post-op visual acuity and complications. There are various surgical variations in SICS, Gerard et al. Method, then the mini-nuke technique by Blumenthal. Ruiz et al. Has devised a technique of funnel-shaped scleral tunnel with V-shaped cancelotomy. Then Malik et al. Has devised AC maintainer assisted nucleus delivery. Then there is double nylon loop technique to reduce the size of the nucleus and the tunnel. SICS is the choice of surgery for high volume surgeries because it's less expensive than phaco and plaques, and it reduces the surgical time. There is less learning curve as already discussed, and it's applicable on all types of cataracts. And also, according to the patient comfort, also it's comfortable. And with good, I think, pre-op keratometry, you can also place the incision on the steeper axis and then reduce the surgically induced astigmatism in SICS. And it allows for early rehabilitation and with fewer post-operative visits. So as I discussed, it requires lesser instrumentations and does not require advanced technologies, which makes it feasible for settings with limited medical infrastructure in underdeveloped and developing countries. And it's scalable. It's performed quickly and efficiently and crucial for addressing widespread cataract backlog. And it can be taught relatively quickly to the newer surgeons who want to learn cataract and expanding access to the cataract surgery. And it helps to reduce the backlog of cataract blindness in the community and significantly impact the public health. So if you see the cost analysis of cataract surgery varies considerably with location, surgical technique, facilities and equipments and methods used to calculate the cost. Gogate et al. In 2017 have shown that the SICS costs $15.3 US, whereas phaco is almost double, which is 42.2 $10 US. And also, Ruit et al. From Nepal, they have also seen that phaco cost around $70 US, whereas SICS cost only $15 US. Gogoty et al. Also have found that the personal cost for phaco will be higher than that of SICS because of the increased surgical time and higher salaries for a phaco surgeon. Houston, in their study, have found that the 20% of cataract surgery costs are related to consumables, and 80% of the cost of cataract operation is related to fixed costs, which are difficult to reduce. Hence, SICS is economically more viable. And if you see the visual outcome, as familiarity with SICS techniques has improved, so has the visual outcome. Gogoty et al. Have reported that visual results of phaco and SICS are comparable, whereas uncorrected visual acuity at 6 weeks were having very little differences. Ruit et al. In their study have shown that visual acuity at 6 months was comparable, whereas they have shown that 90% of both groups had unaided visual acuity and best corrected visual acuity of 20/60. Venkatesh et al. In their study have shown that phaco and SICS both have achieved excellent visual outcomes with low complication rates. If you see the cost, SICS procedure takes lesser time independent of the nucleus grade. The average time for phaco and SICS was 15 minutes, 30 seconds, and 8 minutes, as per Gogoty et al. In their study in 2017. Ruit et al. Have shown that the surgical time for SICS which was 9 minutes as compared to 15.30 seconds for phaco. Venkatesh et al. Have shown that the average time for SICS is 3.75 minutes per case. So compared to phaco, if you see the risk, there are more risk of astigmatism in SICS, as we have already discussed. Gogoty et al. Have shown that there is minimal difference between the two techniques in terms of complications. But in phaco, there are more risk of complications because of the instrumentations. And Ruit et al. Also have shown that there is more risk of getting PCOs amongst the SICS groups than the phaco group. So nowadays, we as an aware, awakened citizen should be caring about our environment. And as more disposable instruments and supplies for cataract surgeries, they have shown that it has a negative environmental consequence in addition to the cost. SICS produces less carbon dioxide emissions than phaco emulsifications. Hence, it's more environmental friendly. Arvind Eye Hospital, India have generated an average of 0.25 kg of waste per phaco emulsification per procedure, 2/3 of which is recycled, in contrast to US, which has generated 2.3 to 3.9 kg of waste per case. All of it are landfill or biohazardous materials. The carbon footprint of surgery at Arvind was about 5% that of the same procedure in the US institutions. Hence, the emphasis should be to reduce and reuse and recycle. So, advances in SICS, I think the subsequent speakers will be talking. You have nowadays mini SICS, topical no patch, control and management of astigmatism, inducing multifocality in SICS, snare technique, my loop technique. And this is a video of a dropless cataract surgery. I'm doing an inferior peritomy, and I'm giving a sub-tenon lidocaine injection, and then fashioning the two side ports. And then doing a rhexis. And with the same cystitome, I am prolapsing the nucleus, tumbling the nucleus in the AC. And I'm doing a transconjunctival, more of a limbal incision. And then doing the visco expression of the nucleus. And then expressing out the cortical matter. And then implanting the IOL under hydroimplantation. And then hydrating the side ports, and also giving intracameral injection of moxifloxacin and subtenon triamcinolone. So this is a dropless cataract surgery, which is very much useful for CAM cases, wherein follow-up is less. So to conclude, SICS has become the surgery of choice in developing countries and set up with a high cataract backlog with consistently good visual acuity post-op and negligible complications. It helps in reducing the burden of cataract blindness and improving the quality of life. And to conclude, I would like to say that the technology that we are applying should be realistic and should address to the existing healthcare system with good clinical outcome. Thank you so much.
Thank you, sir. So another debate is just SICS for the class of the surgery. It's not only for the masses. I request Dr. Pranav, sir.
Yeah, could you ask Dr. Lobsang to stop sharing so then I can
Yeah.
start?
Yeah. Is it okay?
Yeah, fine.
Okay.
You can see the screen clearly?
Yes.
Yeah. Good evening, everyone. Thank you, ARC AIOS, for this opportunity. Today, I'm going to prove that MSICS is a classy premium surgery. For this, I'm going to compare it with phaco, which is considered the benchmark for classy cataract surgery, and prove that MSICS is as premium as phaco in every way. Let us begin with an argument between two famous Indian ophthalmologist brothers dating back to 1975, where one ophthalm brother told the other, मेरे पास क्लासी फेको है, क्लासी टेक्नोलॉजी है, क्लासी टेक्निक है, क्लासी स्नॉब वैल्यू है, तुम्हारे पास क्या है? हाई. To which his brother calmly replied, मेरे पास माँ और क्लासी कैटरैक्ट सर्जरी का बाप है, MSICS. Yes, my friends, MSICS is not just the learning step between ECC and phaco. It is the gold standard in classic cataract surgery. So let us understand the term classy. Oxford Bhaiya defines the word as stylish or sophisticated. Classy also means premium and aesthetically pleasing. Mind you, it is not synonymous with expensive. You can be classy without becoming a papa ki pari. In my opinion, beyond a certain level of development in medical technology, it becomes gimmickry, especially regarding expensive machines. Don't get me wrong, I have nothing against phaco. It is a wonderful surgical technique, but it does not offer any significant advantage over MSICS, especially considering cost to benefit ratio. Let us consider some qualities that make MSICS as classy and premium as phaco. First, the visual results. Innumerable studies have shown beyond doubt that the final visual results do not significantly differ in phaco and MSICS. Yes, there is a certain aesthetic beauty in the video of a slim phaco probe gently pulverizing the cataract and removing it from the eye. But regarding surgical technique, I have seen many of our stalwart MSICS surgeons exhibiting the same elegance and sophistication in their surgery, albeit with far less expensive instruments. Regarding post-op appearance, at the end of a couple of weeks, the operated eye with a phaco and MSICS will appear exactly the same. So MSICS can be a classy, elegant, and aesthetically pleasing surgery. Of course, not all your patients will end up looking like Angelina Jolie overall, but their eyes will look just as beautiful. Please forgive me, I frequently use such images to ensure that my audience doesn't fall asleep. Phaco's biggest selling point is that it can be done through a small incision. But with the advent of Amulya Sahu sir's 2mm MSICS, MS Ravindra sir's 5mm phaco section, Anil Shah sir's snare technique, etc., the incision in MSICS can be brought down to almost the same size as in phaco. Some may consider a subconjunctival hemorrhage in an MSICS scleral incision as aesthetically unappealing. But with a scleral incision, I have the security of a conjunctival flap-covered, perfectly healed incision at the cost of a small subconj hemorrhage that will disappear in 10 to 15 days. I prefer that to a bloodless, clear corneal incision that may not heal completely for months and has a 15 times increased chance of endophthalmitis. Best part is that in other types of surgeries, you have only one boring type of incision. In MSICS, we have many classy types of incision. Straight, frown, chevron. Go ahead and take your pick. The classy advantage of phaco regarding inducing minimum post-op astigmatism has been gifted to MSICS by Boramani sir's customized incision cataract surgery, where we can actually use the incision size and location to favorably influence the patient's post-op astigmatism. Here you can see that Dr. Boramani has reduced the pre-op astigmatism from 1.12 diopters to just 0.15 diopters with a strategically placed incision at the steeper axis. So now an MSICS surgeon can also promise an almost spectacle-free life for the patient. Note that I'm using the words almost spectacle-free because I feel only God can give 100% guarantee of lifelong uncorrected 6/6 and 6 vision after surgery. A classy person can adjust in any situation or with any person. MSICS too can adjust to every type of sophisticated premium foldable IOL. Let it be monofocal, multifocal, or toric IOL. Then someone will ask, Are Pranav, what is this? You are putting a 2.2 millimeter sized foldable IOL through a 5.5 millimeter incision. Isn't that silly? My reply is, I have done my research. Till date, neither the Honorable Supreme Court of India nor my Bhagavad Gita has said that we must put a foldable IOL only through a 3 millimeter incision. So it's absolutely okay to put a foldable IOL through a 5.5 millimeter incision. You won't get a jail sentence, nor will you get bad karma. Then comes an important point to ensure the perfect balance between the classiness of a surgical technique versus its complication rate. We cannot seek style and sophistication at the cost of safety. While matching phaco on almost every point regarding classiness, MSICS tremendously scores over phaco regarding safety and learning curve. With an immature or soft cataract, we get the same aesthetic and immediate visual results as with phaco. With hard cataracts, MSICS will be much safer. The problem of MSICS's lack of status as a premium surgery does not lie in its quality and results. It lies in lack of awareness in ophthalmologists as well as the public. If I may be frank, phaco's status as the classiest, most superior, and the standard technique for cataract surgery is a lie that is sold to us by the surgical equipment industry. And unfortunately, it is us, ophthalmologists ourselves, who repeat this lie to our patients. Then what is the solution? First, we must educate and be convinced ourselves that MSICS is a premium surgery. Only then can we educate patients. The day the entire ophthal community promotes it as a surgery that has the same value as phaco, public opinion will also change. Then we must market MSICS as a premium surgery. Ophthalms, NGOs, government must educate the public about the same. Insurance companies must be directed to reimburse the same expenses for phaco and MSICS. Only then will MSICS get its rightful place on the throne as a premium modern standard technique for cataract surgery. In conclusion, these are the facts about MSICS. It is not only for the economically underprivileged classes, and it is not only a classy surgery. It is appropriate to all classes of patients. As we say in India, Sarva Guna Sampanna. Thank you for your kind attention.
Thank you, Dr. Pranav.
Which is, sir, you are muted.
Yeah, Dr. Malik sir, Dr. Naik sir, would you want to give some inputs regarding both these talks, sir?
Malik sir, you are muted.
Yeah, both the talks were really good. But one thing, as last slide, which I saw from Pranav, that public awareness, and we have to get convinced ourselves, because we talk about this like MSICS is manual is as good as phaco, but when it comes to explaining to the patient, we always try, and the reason is that MSICS has always been given a second-grade treatment by the companies, because any conference, any meetings, not many companies will come forward to support the MSICS conferences for this surgery. But for phaco, there will be 10 companies who will be always ready to support because they have their own economic importance. So basically, we are being guided by not with our own conscience, but with the whatever the company wants us to do that, and this is what most of us are following. So this is what my worry and pain is.
Yes, sir. Exactly, sir. Exactly true.
Professor Malik, sir. Sir, kindly unmute yourself.
Can you hear me now?
Yes,
Yes,
sir.
sir.
So it's really wonderful and virtually summarized by Dr. Nayak also and all you. I think let us listen to the talks and all that. Is there absolutely no way in denying that you would not get a industry support in it. And in fact, every city, I'm especially city-born surgeons, city-born sitting, practicing in big cities. Patients are laser surgery. I tell patients that phaco is also not laser surgery. You have to make a cut. In a femto also, I tell people that now 1.5 लाख का तुम फेको कराओगे femto वाला, उसमें भी कट लगता है. तो वो किसी चीज से लगे, चाहे कट नाइफ से लगे या डायमंड नाइफ से लगे या लेजर से लगे, कॉर्निया तो आंख तो खुलना ही खुलना है. तो दैट बेसिक थिंग वी मस्ट टेल पेशेंट्स दैट entry has to be made into the eyeball to treat the cataract. So is it any of the incisions and any of the things? So patient need to be basic thing told about. There is nothing.
Then it has to go through.
No, but doctors also, Dr. Malik, play a role in this, because those who are doing with laser, they are very clever. There's one sentence: bladeless surgery. What the patient will get impression: no blade, no cut. So this is what they want to convey, which is absolutely wrong. So basically, we are equally at fault.
I can suggest that if you agree, I can take a big press kind of conference in Delhi or anywhere you decide,
Yes.
and we can possibly invite all journalists that and tell that surgery, cataract surgery is this, and SICS is this, and so-called laser and bladeless is this.
Yes, sir.
It's possible.
Sir, our second debate is just related to this. Whether at the start we can start with SICS or directly start with the phaco. I would like to take comments from both our panel experts, Malik sir and Barun Naik sir.
No, but to start at phaco, if anybody who has gone through phaco learning, they would not decide that what troubles they have gone through and how much eyes they have destroyed when they learned the phaco. Because in whether it is a big center or small center where you're learning phaco, it is a poor guinea pigs of the society where you're learning phaco. And SICS, you would not make any guinea pig because SICS not damage the eyes. Even if you do from beginning, if you straight away go to phaco, you are going, virtually you are ruining the guinea pigs. They are the lowest placed persons in society would you choose for teaching or learning the phaco. Unfortunate. That's what is truth in this country.
May I speak something on this
Yes,
topic?
sir. Yes, sir.
Basically, they are dedicated society for small incision cataract surgery. They are promoting other technologies just to get good khana, nach gana, and all that. So these are the like a part of society, and I'm doing both phaco and SICS, and I published my work regularly on YouTube and other even AAO website also. So even Pranav said so many things around this. So he need to little more updated. There are other technique also, nuclear techniques which can be done. Probably he's not heard other techniques or other things. Even one thing, I have recently completed fourth thesis on the SICS of my DNB students. So all good work. If we are going to public on the public domain, like Dr. Parikshit Gokte has published all the work. So even SICS is per classes, and there are so many scientific thing, and there are so many things. Any incisions beyond 4 mm is useless. Okay, so even in the phaco, if you are using 1.8, that causes more astigmatism. So it's nothing to do with the size of incision. It's the anterior posterior stretching of the cornea which lead to astigmatism. So there are so many other things. Even SICS, even David Chan must heard of the topic on the US on the this cataract and refractive surgery. Yes, they learn from the developing countries. So even this is a great topic, and this webinar, there should be regular webinar. Even now, space of for the SICS and AIOS is reducing. When we fought a war for the SICS around 2017 or 18, that time we got the arena back. Malik sir is there. Now, even if we are putting SICS for just for getting political motives for votes, you are not having good speakers on the like AIOS, because you won't go boards. So ये speaker ठीक रहेगा, इसके बाद 20 वोट 50 वोट है, and that mindset should be stopped. Science is science. Even Pranam had presented, and we should present more of video, like not more pictures. This is my particular. So more, if you are putting the strong evidence, so the people will listen that all, or people will see it. In just sharing one thing, even SIC is popular in America also, but reports are not coming. Okay, so this was my few points. Malik sir, would we agree with this? So, we should have like a crusade for this SICS again, because it's a wonderful technique.
In future talks, sir, we will discuss the same thing. But before that, I would like to take the comments from Naik sir. We are discussing about the starting, means which surgery, as per your experience, sir, is better to start first, or give training to resident first on SICS, then FECO, or direct go through the FECO.
You are asking me?
Yes, sir. Yes.
I thought there are two people talking on this topic.
No, sir, there is some issue on
They have
the
just put their
connection.
names, just for the name's sake. They have...
No, sir.
No,
Dr.
sir.
Rupali Mahesh Gavri, Professor Mahesh Gavri is here. She has some issues with her laptop, so she will just be speaking. And Dr. Rajesh Sinha is caught up somewhere in Calcutta. And we have here Dr. Arundhati Dwivedi, who is a FECO and SICS trainer in LV Prasad, Hyderabad. She'll be summing it up for us, sir. But we would first want to hear from you.
Yeah, okay. So, means I think it's not a question of which surgery to start with, whether the FECO or SICS. Basically, all basic surgeries, the basic points of any surgery remains the same. So, how to handle the tissue, how to respect the tissues whenever you are handling it. So, those things, but that way, if someone is given straight away the handpiece in their hand, probably they will not be able to manage. So if you go step by step, then definitely this is the right approach. So not a question whether it's a SICS or FECO. But these days, I am so glad that now those simulators are there. So with the simulator at least, and the wet lab, the actual wet lab, because the problem is that most of the PG students, they just straight away want surgery on patients. They don't want to spend their time in wet lab. They don't want to spend time even on the simulators. So that is the problem. Bottom line is that they should start with the basic surgical skill and procedures.
Dr. Rupali ma'am, is it possible to share your presentation, or you can give the talk directly?
Dr. Arundhati Dwivedi, if you can give your summation, ma'am.
Kindly unmute yourself.
Please unmute.
Hello everyone, it's very good to have a session, especially on small incision cataract surgery, which is very rare these days. I think the previous two speakers, Dr. Lobsang and Dr. Pranav, have very well summarized for us what are the advantages and disadvantages. And I think we already received expert analysis from Dr. Barun Nayak and Dr. Malik, which I very well agree with. Because being a training institute, we ourselves has noted that though there is no published data from our institute on this, we have observed the trend that the trainees who first receive FECO training find it a little difficult to learn sclerocorneal tunnel, or take longer time to learn more skillful surgery. Especially they struggle with sclerocorneal tunnel construction. So I think in training institutions and large volume centers like us, then SICS will be a preferred one to begin with. And also because SICS, as most of us know, that it's a go-to surgery, it's a cost-effective alternative to phacoemulsification. With as multiple studies have already proved by Dr. Parikshit, and we have many more studies from Arvind and all, proving that the visual outcomes are almost comparable. And also we have multiple modifications to reduce the astigmatism in these modern days, even with SICS especially. And also we have observed that especially trainees struggle, as Dr. Barun had already mentioned, that trainees do not want to waste their time or spend their time working on the wet lab, on the animal eyes, or on the simulators. They straight away want to go and do it on the patients. So in that scenario, I think a technically more challenging phaco will be difficult, or might have a little longer learning curve and might have more amount of complications. So unless and until they have good command on the technique and machinery. So I think, yeah, SICS is better compared to phaco to start with, especially I would say in setup with longer waiting times and with high volume centers and with minimal setup. So I think resource limited centers is yes, and high volume centers I would definitely prefer SICS over phaco.
Thank you, Dr.
One thing, can I add one thing?
Yes.
Yes, because what is uncommon about fake one SI, that's a nucleus management. And one thing, if somebody is going to just for swimming, what will you give first? Life-saving jacket or something like that. So SICS is savior or life-saving jackets. So most of in India, people are starting with SICS, and we also run a training institute DNV. So what we give a step-by-step approach under supervision. First year we'll do the conjunctiva, and second year we'll do the tunnel, and third year will then the last part is the IA. So this is our way to teach and this is the I think most practical, and without even the live patient, it's not going because consultant is always there with them. It is something unsupervised surgery is leading the complication. Otherwise, later on you have to hand over a patient to them also. But step by step, it doesn't uh, uh, harm patient. It's our view in our institution.
Thank you, sir. The catch point is whatever surgery residents should start, they will first spend some time on the wet lab, and the surgery should be done under the supervision. So we
Yeah.
move to our next talk by Dr. Priyanka Boramani. She will be speaking on the customized incision cataract surgery. Dr. Priyanka,
Good
please.
evening. Yeah. Okay. Yeah, you can see the screen.
Yes.
Oh, 1 second. Yeah. Okay. Good evening, everybody. Firstly, I would like to thank the AIOS ARC committee for giving me this opportunity. So I'll be talking about the customized incision cataract surgery. Before we begin, I would like to show you all two cases. So in this case, as you can see in this topography, the astigmatism is very less, it's hardly 0.1 diopters. And by just doing the SICS surgery, we reduced it further. Now in the second case, you can see the astigmatism is as 2 diopters. And by doing the SICS surgery, we reduced it to 0.4 diopters. And the patient, this is the autoref and the keratometer readings, and the patient is 6'9" and 6 unaided. So how is this possible by just doing an SICS surgery and not using the toric IOLs? So we know that the scleral tunnel incisions are very kind in nature, but also published literature says that they produce more astigmatism. But this induced astigmatism that they produce can be used to correct the pre-existing astigmatism. We all know that a straight incision produces the maximum astigmatism. So to combat this, the frown incision was invented, whereas the chord length remains the same and the periphery is away from the limbus. So we thought, what if we curve the incisions further? The astigmatism reduces further. So based on this, we have made our own algorithms wherein the superior straight 7 mm incisions causes an astigmatism of 1.6 diopters. And as and when we reduce the length of the incision, the induced astigmatism further reduces. Now the curved incision produces even lesser astigmatism. And as we curve the incisions further, the astigmatism reduces subsequently. A perfectly U-shaped incision practically produces no astigmatism. The temporal incisions are not very effective in inducing or neutralizing astigmatism, but still, even here, when we reduce the length of the incision, the astigmatism reduces subsequently. The temporal curved incisions further induce lesser astigmatism. The superotemporal and superonasal incision, the SIA lies somewhere between the temporal and superior incisions. Now, not all patients would have like the K1, K2 at the perfect horizontal or vertical axis. There could be any oblique astigmatism, any kind of astigmatism. So it is important that we center our incision on the steep axis, whatever may be the size or shape of the incision. So the vector forces act equally from both the sides. And also, whichever may be the steeper meridian, we get the upper hemisphere of the eye to operate upon. These are certain SIA calculators which are freely available online. In this, we can find our individual astigmatism. And once we know in our hands what kind of incision behaves in what way, we can further customize the incision and get better results. So again, I'll show you some more examples. Now, again, in this case, you can see he practically has no astigmatism, just 0.2 diopters. So by taking a superior U-shaped incision, we not only did we induce astigmatism, we further reduced it to 0.1 diopters. Over here again, we took a superior temporal incision and brought down the astigmatism from 0.3 to 0.2 diopters. Now over here you can see it's a 1 diopter astigmatism, the steep axis being at 97 degrees. So superior straight incision brought down the astigmatism further. Here we took, it's again a very less astigmatism at 4 degrees. The steep axis being at 4 degrees, with a minimally curved incision, we could bring down the astigmatism even further. What about high astigmatism? This is almost a 3.4 diopters of astigmatism. And we brought it down to 0.6 diopters by taking a straight 7.5 mm incision on the steep meridian. So I think if we were taken a longer incision, we could have further reduced the astigmatism. And the induced SIA was 2.98 diopters. Over here, the astigmatism of 3.3 diopters, we reduce it by taking a superior straight incision to 0.5 diopters. And the induced astigmatism is 2.75 diopters. So what this means is that by placing the incision on the steep meridian and with our own, like doing some more cases and figure out your SIA, we can, this induced astigmatism can use to neutralize the astigmatism. So basically this 2.75 diopters of induced astigmatism helped us neutralize the astigmatism on the other axis. So this is a case of high astigmatism. So this patient, we gave him the option of toric IOLs, but the patient was not affording. So we did a straight superonasal incision and brought his astigmatism down to 0.15 diopters. The patient is very happy. He's 6'6" and 5 unaided. This is another similar case of 1 diopter for astigmatism. This patient, again, we gave him the option of a toric IOL and also of and also we explained our method to him. And, we thought that instead of paying the IOL company for the lenses, he can pay more surgical charges to the doctor and he'll get the same result. So Again, this astigmatism was reduced to 0.25 diopters. And the patient was happy. This was again, we took a supero-nasal straight incision. So I think this became a premium surgery without a premium IOL. So I think, and whereas in the previous case, without charging extra for the patient or the patient have to pay for a very premium lens, it became like a charity to the patient. So I think as Dr. Pranav sir mentioned, that SICS could be like a premium surgery and also a surgery for the masses. Since the surgically induced astigmatism, can I just take 2 minutes? Astigmatism is used to neutralize the pre-existing astigmatism. I think it's high time we give it a more respectable name and called it the surgically corrected astigmatism. And the surgery is customized incision cataract surgery.
Great.
So as we do in the toric IOL over here also, we marked the reference axis of 90, 0 and 180 degrees in the sitting down position. And then in the supine position, we mark the steep meridian. It is important to center the incision on the steep axis. Here you can see on the right side, we are making a straight incision. And on the left, they were taking the curved incision at the 70-degree meridian. I'm happy to say that this method was announced in the was published in the IGO in November 2022. I'll just show you something interesting. Now, just hypothetically, let us assume that there are two patients having the same amount of astigmatism, say about 2 diopters, and we did the same type of surgery with the same, exactly the same incision. But unfortunately, we undercorrected it and there was a residual astigmatism of 0.5 diopters. And in the second case, there was an overcorrection and the residual astigmatism again of 5 diopters, even though the axis must have changed. But still, we get a range of error of 1 diopters. And so somewhere, even if we go a little off the mark, we get a range of error and the astigmatism will lie within it, which is still much less than the pre-existing astigmatism of 2 diopters. So I could just conclude by saying with customized tunnel engineering, it is possible to wipe out or at least minimize the stigma of astigmatism. Thank you.
Thank you, Dr. Priyanka, for the wonderful talk.
Thank you,
We
sir.
will move to the next talk and then we will summarize both in one. Next
Okay.
talk is by Smart SICS and Dr. Satish Seth sir will deliver his talk. Dr. Satish sir. Sir, kindly unmute yourself. Dr. Satish sir, kindly unmute yourself. Sir.
Yeah. Hello.
Yes, sir. Yes, sir.
Yeah. Can you hear me?
Yes.
Yes.
So,
Deepak? Yeah.
Yes, sir. You are audible.
Yeah. Shall I share my slides?
Yes, sir. Yes, sir.
Okay. At the outset, I wish to thank the AIOS ARC committee and Dr. Parikshit Gopte sir for having invited me for this prestigious webinar. So, incidentally, we happened to meet Dr. Raju Raut at the first World Conference of ISM SICS at Pune. And that's where we were introduced to this concept called Smart SICS. So these are my financial disclosures. And I belong to a city of Hubli Dharwad, which is known for many of these things, you can see the former First Lady of UK there. She was born in the same institute where I am working at present. And we have the world's longest railway platform and the mouth-watering pedas. So when it came to smart SICS, so there were two wonderful words on which I have to really disclose to the people. One is, I was fascinated, and whether was it a one-hit wonder. So by fascinated, I want to see the definition. It is to think about something all the time. And one-hit wonder is any entity that achieves mainstream popularity, often for only one piece of work, and becomes known among general public solely for that momentary success. So was it the both? But it wasn't so. So we came back home and tried to do our surgery. Still, we couldn't believe what was really happening. And later on, again, we started
is only sitting as
looking at
me
this
in
video,
you.
whether
These two only
it
is
is
talking
the
to
same
each
way
other.
that people
Understand,
would
I can only talk to
respond
me
to
and
this
give my
particular surgery,
understanding. I
or
cannot talk
is
to
it some
anybody
kind
else
of
and give my
gimmick,
understanding.
or is it some kind of
So the
some magic,
me
or trying to just pull people around?
resides in this
So
as me,
then we moved
is
on
residing
to
in me.
a concept what Dr. Raju Raut shared with us. He gave an example of a balloon which has been held tightly over a cork ball, and you try to take a knife and make an incision. When the ball is held and the blade is held horizontally, because of the stretch, the balloon tends to get cut horizontally when make a vertical incision, and the same incision when taken horizontally doesn't cut through. So he gave us a principle of law of elastic domes, by which he meant that for every change in the curvature in one meridian, there's an equal and opposite change 90 degrees away. And this conic behavior is known as the coupling effect. So now what happens is the vertical meridian of the cornea is steepened by stretching the horizontal meridian, that is by the law of elastic domes. The incision is always taken superiorly at 12 o'clock, and the incision size is 6.5 millimeters. And the SICS incision is used as a relaxing limbal keratotomy to flatten the upper half of the steep meridian. Then what happens to the lower half of the steep meridian? The lower half of the vertical meridian remains steep, and it improves the near vision. The smart SICS neutralizes the steepness in the upper half of the vertical meridian and maintains the steepness of the inferior hemimeridian to get good bifocality. So now I shall be briefly describing the surgical steps. So it's a routine SICS surgery. You take an incision at about at 12 o'clock. You can measure the incision, take it a 6.5 mm incision, and there, once you enter the antechamber, you infuse viscoelastic on at 3 and 9 o'clock position. Okay. Then this was the ring, which is a translucent ring provided by Dr. Raju Raut when we first attended the first World Conference of ISM SICS. There, continuously while filling the viscoelastic into the antechamber, you try to look through the central hole and see that the Myers are vertically oval. Okay. And if it is a circular Myers all round, then no need to do more stretching of the horizontal meridian there. So then you perform all the steps of the SICS as a routine case, and the stretch at the moment of the entry of the keratome into the antechamber decides the fate of the cornea. And his prediction is that the cornea, once stretched, will not revert back to its original shape after this particular stretch is done. And to our surprise, we found that we could achieve a good bifocality with a monofocal IOL. In most of the cases, it was nearly about 85% of the cases. Then we had the opportunity to present this in multiple forums, and I'll just, yeah. So this is our study period there. from the year 2016 to 2019, we have a discussion, Dr. Parsappa Bandarkalli, on this particular subject. So he's also a professor in Ballari Institute of Medical Sciences there. And many of our postgraduates have taken up this as a thesis topic. And this was our random sample size during those 3 years, where the mean follow-up was about 4.5 months, and patients were belonging to the age group of 50 to 80 years. And pre-op astigmatism was about minus 0.5 to up to 3 diopters. Okay. So the uncorrected distance visual acuity was 6.9 plus in about 70% cases, and 6.9 plus in about 16% cases. And the near vision acuity in the same cases were N8 and N12, and only about 12% of the cases we could not achieve the good bifocality. So what are the advantages of this particular technique? Is that we can get a multifocal vision at a monofocal cost, and near independence from spectacle from the day-to-day activities, and no problems like halos and glares associated with the ringed multifocals. And you don't have to worry about the pre-existing astigmatism, irrespective of the amount of astigmatism, its extent or axis. And what are the limitations for this? Now, this particular technique cannot be mastered just over a day or two, and you cannot learn it like phacosurgery. All that is required is patience, patience, patience. And whenever you have this patience, you have to under-promise and over-deliver. Tell that your patient is likely to have a good near vision without a multifocal eyelid. And the main key aspect is that you should ensure the proper endpoint, that is to reach a perfect circle or at least a vertically oval circle when you are the image that is seen on the cornea. And with practice and patience, a very favorable outcome is assured. And this is the presentations that we presented in the second World Conference of MSSCS at Chennai. And we already have publications also. Dr. Parsappa has been the chief author for this. And now we can claim that this is an established technique. All that is needed is some more refinement of the technique, where now Dr. Raju Raut has developed a software called K2K, and he has been successful in doing these surgeries with the software. And for the patients, I would like to bring to the notice of the audience that you should remember about this dog by name Hachiko in Japan, which waited for almost 19 years, say more than 9 years, waited for the owner to come back from the Shibuya railway station where the owner had left him. And this is the day when the dog died. The entire railway staff of the railway station had to pay the homage, and the statue also of Hachiko has been erected there. And if you look at our own scriptures, you can see the way Shabari waited for Lord Rama to get to him to provide those berries and relieve her of her sins. So these are the references, and we have got a smart YouTube video from Dr. Rajiv Rao, and these are the publications that we have got at present. And this is the patient that we had operated only about a week ago, and you see how comfortably the patient is reading N6 on the first post-operative. Thank you for your kind attention. Thank you.
Thank you, sir.
Thank you, sir.
Deepak, may I add something?
Yes, sir.
So that was a great presentation, Dr. Satish Dishit, as usual, and it's all about hope. And the amount of hope you provided using SICS, that exemplary. So hats off to you and this innovation. Thanks a lot.
Thank you, sir.
Dr. Parsappa Bandarkalli, sir.
Yes, sir. Good evening. Am I heard, sir?
Yeah.
Yes, sir.
Yeah, I would like to share my thing. You have my slides, or I would share, sir?
So you have to give
Sure.
your views and
Yeah.
discussion on it.
I'll share it.
First.
Is it okay now? Is it being shared, sir?
Yeah, I can hear you. Parsappa, yeah.
Sharing is done?
Your slides are not visible.
Yeah.
Deepak, can I make just one
Now?
comment about these two talks?
Yes, sir. Yes, sir.
Because again, I will come down to the same point, that means whatever the earlier talk and the second talk, both were very good, but definitely it needs more evidence, more publication and robust publication. Say, showing anecdotal cases, some selected cases, entirely different thing. But if this is the result of the entire group and the large group, then it has a lot of sense in it and it will add a lot of value. So I will request that both the talks, that on these things, we need more data, we need more publication, we need more robust publication.
I agree with you,
Yes,
sir.
sir.
And we are ongoing. There are clinical trials head to head. And hopefully within 8 months, they will be ready for publishing. Thank you, sir.
But then it's not only one publication, because I want,
Yes,
because
sir.
if say multiple people are doing this, and
Yes.
because in FACO you see there are, means you can't even count how many publications are there.
Absolutely, sir. And
Yes,
So unless it does that, SICS also, then only there will be some competition, tough competition.
Yes,
So
sir.
that is the
Absolutely,
thing
sir.
which we are lacking.
Dr. Deepak, I have a point. That's why I'm saying if you should have a data, and data is like not presenting one case and other way. There are so many cases other than this who are reading distant and near, and even Dr. Seth had not produced any scientific data, even particularly estimate also. So even stretching cornea with one putting, this is totally scientific, I would say, with all responsibility and all these things. So I would say this talk is okay. I have debate with many time in this, and I'm ready to debate on this because this is science. There should be scientific data. What we are, I'm saying that माउंट आबू में सुधीर सिंह रहता है इसलिए सन निकलता है, तो दोनों बात सही है कि सन भी निकलता है, सुधीर सिंह भी रहता है. So we should not be like that. Science is science, and I second totally Nayak sir. He has like pioneer in publishing data and editing data. So we need good data and double control mile, double mass data. It's not like biased these things. So on that point.
Very true, sir. There are a lot of studies already going on the both techniques. Hopefully, we will have some more publications and in the peer-reviewed journal to verify these things.
I agree with Dr. Deepak that the future is really bright for M6 because now we have robust data and there are a lot of systemic meta-analysis also coming up, which are the highest order of evidences. So future is really bright, but we all need to work together. Yeah.
Mr. Badrikal, please.
And also acceptance, as Nayak sir has said, that the FACO acceptance and the FACO publications, they are more. So we need to change the whole the way the ophthalmology world is watching towards us. We really need to work on this as a team.
Yes, sir. Can I start now?
Yeah.
Yeah. But sharing is missing. Can we? Yeah, before that gets shared, yeah. We have, all of us probably, Dr. Satish Seth and myself, both of us have to thank Dr. Raju Raut because I think he showed what this kind of surgery, smart SICS actually. One kind of SICS which was being done by him was named by probably this group as a smart SICS. Although we cannot publish this as a smart SICS, I think we published this with a big title, including the principle of that or what we did for this modification for this particular surgery and gave the results. So can you share my slides? Am I heard, sir?
You are audible, but the slides are not visible. Your slides are not seen.
Yeah, that's what. I have shared actually. It is showing.
You can share again, please.
Yeah, I'll share again. Is it okay now?
Yeah.
Yeah.
We can see your slides.
Yeah.
Yeah, please.
Yeah, at the outset, I would like to thank Dr. Parikshit and Dr. Satish Sheth and also AOS ARC for giving me this wonderful opportunity to be on this webinar. Yeah, I also said about the second place that we have given to SICS. I think we should not have. Maybe the industry, I think, as others also pointed out, I think, has given a lot of importance to the phaco, and we ourselves are seeing SICS as a less important surgery, but we should not have done so. But there are a lot of modifications that are being done. One of them is Dr. Raju Raut's. So since we went and saw there, we didn't believe that. So we thought we will do a study. As soon as I came over here and we did a study where we did 40 cases each. That is case control study where we enrolled 40 in cases and 40 in controls, where stitching as described by Dr. Sheth and also Dr. Raju Raut we did, and we analyzed after 1 week, 1 month, and then after 6 months also. So we excluded few of them, that is pseudo exfoliation, because a lot of stretching can lead to this thing. I mean, weaker zones can be a little more weaker. So we avoided that, and retinal pathologies and one-eyed people also were avoided in our study. So we just took WHO standard as a this thing, where we got probably more than 98% to 100% of the people got 618 unaided vision as far as distance, because many surgeries that we do aiming for presbyopia correction in cataract surgery will be compromising distant vision. So we didn't want that. So we looked at distant vision, where we got almost in 98 to 100% of both cases and controls. So there is hardly any difference between this outcome as such. And near vision, you look at the near vision, in cases, more than 75% of the candidates had vision of more than N8. And only less than 20% of them, that is at the end of 6 months, only 17% of controls had N8 or better vision. So this obviously tells that near vision probably was good, and as we already told that distant vision is not compromised. So this proved, it convinced us that this is a good surgery where we definitely can go ahead and look for a multifocal or bifocal at least without any or dysphotopsia and all other complicated issues with multifocal IOLs and greater surgeries like lasers and things like that. Without this, we can definitely give. That's what actually was convincing with the paper that we published. And people in these cases actually required a very less number of very less of additional glasses for near. Look at the end of 6 months, this was clinically significant also, where many of them were able to read only with 1.5 N6, many of them, and very few of them required 2.5. So ranging between 1.5 to 2.5 at the end of 6 months was really convincing that where controls had actually, they required more than 2.5, around 2.5 or so. So definitely this will scored over the controls. Okay. The only thing against this was surgical induced astigmatism was claimed to be less with Dr. Raju Raut's this thing, but it is not so. In our study, actually, it was better in controls than cases. I don't know about this with Dr. Sheth's study, but in our study, we got more of astigmatism in cases. So I think with this, I would conclude my this thing. Thank you.
Thank you, sir.
Yeah.
Kindly stop sharing.
Yes, sir.
And
Hello.
we
Hello.
move to our next presentation. Sir,
yes, sir.
We move to our next presentation because
Can
of
I
lack
speak? Can I
yes,
speak?
Yes,
yes, sir.
See,
Yes,
I'm
sir.
the chairman, Mr.
Yes, sir.
Mishra and everybody.
Yes, sir.
You must at least control the timing, and subject should be reduced to minimum timing and all that. Let's discuss after 2-3 papers or something.
Sure,
And when
sir.
we are talking of pure science, please ask them not to dilate so much about something which is not absolutely provable or proven already. So please stick to the already things which we know, and we can improve.
Yes, sir. That's why we are moving to the next topic, sir.
Please finish
Yes.
the talks, because otherwise,
It will
and
not.
keep me unmuted.
No,
So I keep control of the timing. I would not allow people to just, instead of 6 minutes, you take 10 minutes. You can't sit here
Sure.
2 hours.
So our next speaker is Dr. Aarti Heda. She will be going to present various techniques to reduce astigmatism in SICS. Everyone again, please, one request, finish it on time. Dr. Aarti, you are muted. Kindly unmute yourself.
Okay, so good evening, everyone. I'm sure my presentation is going to be very short because most of the points have been covered by previous speakers. So at the outset, I would like to thank Dr. Parikshit Gupte sir and team ARC for this wonderful opportunity. So astigmatism and SICS, probably this is the very hot topic which is discussed in most of the SICS meetings. So when we talk about astigmatism, how do we reduce it? So I have divided my presentation in a few points. So let's go one by one. So preoperative planning, you should do a good keratometry and topographic assessment to determine the degree and axis of astigmatism. So for pre-existing astigmatism, place the incision on the steep corneal meridian to flatten it through the incision's vector forces. Now, limiting the corneal incision size and location. So when you take a smaller incision, like reducing the size of the incision helps minimize the astigmatism. Placing the incision in an area of the cornea with least curvature, which is usually the temporal or superior cornea, helps reduce the likelihood of inducing the post-operative astigmatism. Now, to support these 2 points, I'll just talk about these 2 studies which were published in IGO. So Dr. Amulya Sahu and his group has published about the early post-operative astigmatism in 2 mm manual MSICS with fracture. And they proved that the astigmatism induced is very little. The number of eyes studied was 66. And the second study, which has already been discussed by Dr. Buramani, was customized incision cataract surgery, where astigmatism modulation technique in manual small incision cataract surgery was discussed. So the highlights of this publication was use of incision on the steep axis, with the external incision configuration being used to modulate the residual astigmatism. Surgical technique has been reliably used for correction up to 1.75 diopters of astigmatism. Thus, the pre-existing error up to 2.25 can be tackled with this technique. Now, incision size used has been from 5 to 7 mm or beyond, depending upon the intended needed to be modulated. So the third point is wherein we talk about the corneal architecture. Please, can we mute Dr. Haight? So a well-constructed wound is very essential, and it plays a big role in astigmatism. So ensuring that the wound edges are smooth and well-aligned can reduce the astigmatism. Well-closed incision avoids wound gaping and torsional forces that can lead to post-operative corneal irregularities. So now, if the sutures are used, placing airtight and precise sutures help achieve proper wound closure and thus reduce the astigmatism. It is important to use non-absorbable sutures like tenonylon we generally use in a manner that minimizes the distortion of the cornea. The next point I would like to talk about here is toric IOL, which are designed to correct the pre-existing corneal astigmatism. So in SICS, choosing an appropriate toric IOL based on the pre-operative measurements can help to correct the astigmatism by compensating for the corneal curvature. Alignment should be done properly, ensuring that the correct meridian alignment with the steep axis of the cornea is done. And you must know your surgically induced astigmatism to calculate the correct toric IOL power. So, post-operative management, if there is significant astigmatism still there after the surgery, or if you have induced it, then you have a few options like laser refractive surgery or additional keratectomy can be considered. Now, what is astigmatic keratotomy? It involves making precise shallow incisions along the steep meridian of the cornea to reduce the steepness of the corneal curvature. It can be performed at the time of SICS or post-operatively. Now, cuts are typically placed in the limbal area or within the corneal stroma, and are intended to flatten the cornea's steep axis, thus reducing the overall astigmatism. I'm really not sure if there is any published data regarding this, and I would like Dr. Arvind Moria sir to comment on this, if any. Now, in cases of excessive astigmatism post-SICS, selective suture removal or adjustment can be performed to reduce the corneal distortion. One can remove or loosen the suture selectively based on the corneal shape and astigmatic axis, which you can determine by doing a good corneal topography. Now, highlighting the basics, dry eye or irregularities in the tear film can exaggerate the perception of the astigmatism. So therefore, ensuring the ocular surface is healthy and managing conditions like dry eye can definitely help reduce the apparent astigmatism. So you should assess the ocular surface pre-operatively as well as post-operatively. So doing a customized surgery using a good biometry can also result in very good outcomes post-SICS. So utilizing advanced corneal mapping techniques such as topography and tomography helps in accurate preoperative measurement of corneal curvature and astigmatism. It aids in planning the incision location, size, axis, as well as selecting a toric intraocular lens if at all it is needed. So to conclude, by combining these strategies, SICS can be performed with a lower incidence of post-op astigmatism, leading to more favorable refractive outcome for the patient. And each technique must be chosen based on the individual patient's corneal and refractive characteristics, as well as the surgeon's skills and experience. So thank you, everyone.
Thank you, Dr. Aarti, for finishing on time. We will take quick comment from Dr. Moria and move to the next talk by Dr.
So Dr. Aarti, a very crisp and clear message from your talk. So yes, SICS can be customized. Of course, there are a lot of techniques. Boromani sir has developed that algorithm. And also by reducing the incision size, 2 millimeter and all that, yes, it can be customized. But there are only a few published data available in PubMed literature. I was going through it. And also those data, they are very short term, up to 6 months only. So we need to wait and watch how come it fares in long term. So we need to wait in long term results, but it can be customized, of course. We are also trying it, doing the incision on the steeper side, and we are getting good results. So at least we are doing something for the patient who cannot afford toric or the premium IOLs.
Can I just add, because I had conducted a study, Deepak, can I just add a line?
Yes, ma'am.
With your permission? Yeah. So we had also conducted this study, and I had used a straight incision to actually induce astigmatism. And what we found was the maximum amount of astigmatism that could be corrected by wound modulation was just 3 diopters. So anything beyond 3 diopters, I think we should never promise the patient that we can correct. The other thing is, of course, toric lenses, they are they give the most reproducible results. So there is no, denying that that is still the best option. If, of course, the patient cannot afford toric lenses, then only we should go for wound modulations, and that also between 1 and 3 diopters. Thank you so much.
Dr. Sudhir, you are inducing astigmatism and to provide multifocality. Any comments?
Sir, we will take comments later on.
Okay, no problem.
Short of time. Dr. Nilut Parna, she will be speaking on 2 mm SICS, and we will discuss as Rick sir suggested, after 2-3 talks, there will be some discussion. So after 2 talks, we will have a discussion with everyone. Sir. Nilut Parna, please. Kindly mute yourself. Unmute yourself, sir.
Yes, thank you so much. First and foremost, I would like to thank AIOS ARC for this wonderful opportunity. Thank you, Parikshit sir and Dr. Deepak Mishra. Today, I'll be speaking on the 2mm MSICS with back cuts. And I have no financial interest in this presentation. Is my slide moving?
Your doctor is visible. You can start, please.
It is not moving, right?
It's visible, doctor. You can start, please. It's also analyzed along.
Yeah, it is visible, but it is not moving right now. Just 1 second. I'm so sorry to disturb you.
If there is technical issue, then we can request our next speaker. Meanwhile, Nilufarna, you can.
Okay, can you make it full screen once?
Is this okay now?
All good, doctor. You can start, please.
Yes. Yeah, thank you so much. I'm so sorry for the time that we have lost. So we have seen that there has been a lot of changes in the wound architecture, as well as the amount of work that we have done in the nucleus delivery system, as well as the fragmentation of the nucleus. So when we are talking about these different techniques, it is important for us to understand the basics or the physics behind the procedure as we are doing it. So if you take a simple model that we have created here, you will see that this roof or the elastic lamina of the sclera is represented by this dome of the model. The surface is by the bed of the sclera. The object 1 is the wire vectis that we are using to deliver the nucleus, and the object 2 is the your nuclear fragment that we deliver. And the red arrow that is showing is the way we deliver the nucleus through the tunnel. So the force that is exerted on either edges of the wound is by the force T, that is the restoring force. So as we I'm so sorry, there is a little bit of noise. I'm so sorry. So to unveil, can I? I'm so sorry. Can we take the next presenter, please? Because there is a lot of bombarding happening outside. I know somebody is still celebrating Diwali till today.
It's okay.
Really
We can hear you completely fine. You can continue,
sorry.
please.
I'm really embarrassed by this all the sound that is happening outside actually. Okay, so let me come back again. So we need to understand that when the vectis and the nuclear fragment is in the tunnel, the height of the tunnel is increased by D. That is, from if the width of the lamina is L, it changes to L dash. So the stress that is being induced at both the ends of the tunnel will also change according to the area amount of extension that we are doing. So as we go beyond in the sclera, behind the sclera, we have to understand that we cannot proportionately keep on reducing the size of the incision, because this will escalate the tension force on the wound. Therefore, we have to put the back incisions on either sides of the 2mm incision such that we can create scleral pockets in order to increase the amount of width internally, not externally. So you can see that when there are 2-3 more forces that are acting when we are pulling out the objects from the tunnel. So there is the frictional force that acts between the vectis and the surface of the sclera. There is a frictional force there is a threshold force that is acting between the object, that is nuclear fragment number object 2, and the vectis that is holding it. And also there is a limiting force that is acting between the object 2, that is the nuclear fragment, and roof of the tunnel. So when we try to increase this frictional force between object 1 and 2 and try to pull it harder, what happens is that we are increasing this T sine alpha, that is the inward force, that is the force that pushes the sclera down and it pulls on either side of the tunnel. So in order to reduce that, what we need to do is that we have to keep the angulation of the vectis at an angle theta, that is, it should be tilted a little up and forward so that the nuclear fragment is slides easily through the tunnel. In order to aid this, we also inject OVDs between the roof and the nuclear fragment. So we understand from Hooke's law that if everything is happening according to the proportional limit of the stress property of the sclera, then what happens is that the membrane, that is the elastic lamina or the sclera, will return to its original length when the objects are out of the tunnel. But if we if we tend to increase this force or minimize the amount of incision size more and more, then there will be a fracture or a breaking point which will be reached and the tunnel will distort. So to start with the incision, you see, we have taken a 2 millimeter incision 1.5 millimeter behind the limbus, and we have placed the back incisions before we have created the scleral pockets. This is important because we need not create the scleral pockets before, we need not create the dissection before we create the scleral pockets. Otherwise, there will be purse string effect. So now we are trying to create the scleral pockets on either sides. And as we enter into the cornea, the entry into the cornea will be determined whether we are going to use a foldable IOL or we are going to use PMMA IOL. If you are going to use a foldable IOL, an entry into the cornea of 4 millimeter is enough because the width of the vectis and the height that I had already described before, where the vectis and the nuclear fragment will be inside the tunnel at one point of time, will be almost equal to 4 millimeter. So as you enter, it should be diagonally. You can see here, I have gone a little diagonally so that I do not cut the edges of the 2 millimeter incision. So using the scleral pockets that we have created earlier, now I will introduce the vectis behind. This is a non-irrigating vectis behind the nucleus. And then with the tapered end of the continuously irrigating cannula, visco cannula, I separate the two nuclear fragments and will glide it out of the tunnel at an angulation. And the next fragment is also done. So the successful execution of this process was done because there was, without tearing the scleral tunnel, would indicate that the stress that is developed in the scleral membrane was within the elastic limit. But you see, if we do not create the scleral pockets and try to create a trapezoid type of incision to deliver the nucleus, as I have discussed before, we will create a purse string effect at the tunnel. So the breaking point will be reached here. But in the same way, if we try to increase the wound by not making it a frown incision, what we end up is that the stress goes beyond the proportional limit, but it stays within the elastic limit. So what will happen is the membrane will still rebound, but slightly, but it will not come to its original length. It will be more than the original length. So the purpose of 2 millimeter incision will not be served. It will be beyond 2 millimeter. So we had conducted a few studies. This was the early post-operative astigmatism measurement that we had done between 2 millimeter and 6 millimeter. And we induced only the astigmatic error changed marginally by 0.5 diopters. And we saw these are some of the pre and post-operative. I am just showing a representative photograph where the surgery induced about half a diopter with a pairwise correlation. The endothelial count was also published in the literature, which was almost equivalent pre and post surgery. We had also compared it with phaco, and the surgical outcomes were almost comparable. But this type of technique has a learning curve. It has a very steep learning curve where you can end up with pulling out the superior iris, or you can end up with a lot of corneal haze if the scleral tunnel is not made properly. Therefore, I insist that the physics of the procedure needs to be understood before embarking on this technique. So this is how the scleral pockets are to be made in a 2 millimeter incision with back cuts and not in a trapezoid manner, which I have already shown by the videos that the mistakes that I had done in my initial stages. And these are some of the references. One of our large article that we have already done over the last 2 years is still in publication, and I hope that I can bring that up to you shortly. Thank you so much for your patient hearing.
Thank you, Dr. Nilipanda. We will move to the next speaker, Dr. Sudhir Singh, sir. He will going to present his topic on SICS glaucoma. Sudhir, sir, please.
Can I share now?
Yes, sir. Please, sir.
Just a point on the previous talk. Actually, the 2 millimeter size is misnomer. Incision is whatever incision, whether it's straight or here. So, sir, you will count if you just take the perimeter of this incision is almost 6 millimeters. So on this, I start my talk. So, hello, is coming?
Sir, yes, sir. No, sir. Kindly share your screen, sir.
Sir, you need to reshare, please.
Just a minute. Is coming? Is coming?
Yes, sir. Now it's coming.
So,
first kindly put timer.
So I'm not comfortable with the Zoom. I'm present second or third time with this. So this is my incision basically. This is triangular, like you can say that this is the triangular incision. And dissection I do with this crescent knife. And I'm not skipped the indication of SICS with glaucoma. So this is how I dissect my scleral flap first with this. This is triangular. I hope it's visible, very well visible. Now I extend a little bit of pockets. This is I've skipped now rotating the nucleus because this is simple as other SICS. I would put all precautions to nucleus before and after entry and posterior surface of the nucleus. And now nucleus is delivered. You may employ your technique, whatever it may. My technique is this backtips technique. If nucleus is more, I can break in the tunnel also. I use bimanual phaco automated irrigation aspiration, and it's very good. So I always phaco machines on my table, and I take many phaco good steps in intricate phaco IA. I also do with the Simcoe cannula. So it's individual matter. And one thing, just I routinely done this, so I can skip this. Now this is just a minute. So then I give the radial cuts like this with just a minute here. So this is with 15-degree blade. I give the radial cut, and now this is just separating anterior part of flap. Now cut this deep sclerotomy part with the scissor. So this is the deep sclerotomy tissue. And now PI. Pushing back the iris. Just checking whether the the iris opening is full thickness or not. Now just I'm checking whether this is my usual way to check whether my this filtration surgery will be going to be successful or not. So I think the utility. Otherwise, I extend a little of little more wide deep scler part. Now I use the removable sutures. So first suture, just this is a fixed suture. Just I'm skipping it. This is a fixed suture, and this is fixed suture, and now this is removable suture. I'll show you in the last. So once I tie it on the slit lamp, I just give a nick here. So this suture is released. This remain outside because yeah, this is suture. When you need to remove it, just give nick here, and this like suture is you can pull it on the slit lamp. This is second suture. I usually keep suture little tight because when you are doing combined surgery, your AC should be maintained for initial 5 to 7 days. Otherwise, your IOL will be popped up. And in this particular type of surgery, I use the PMMA lens, my favorite lens. This is at the last. Now I will just show you how to check whether this surgery is working or not working. You can see here. Here you can see. So this plug is functioning, and this is a patent also. So at the end, I'm checking the pressure whether AC is well formed, well pressurized, optimal pressure, and this is how I do the SICS with the trabeculectomy, and it's good for our population who cannot afford two different surgeries, or they cannot afford the medication for longer time. So all indications may be good for the metros, or maybe but for rural area and other area, we prefer to do the combined surgery because patient doesn't turn up for most of time. For this is here leaking here, so I'll put one suture. I think this is on video or not, I don't know, but once it's there, then this is watertight closure of the conjunctiva, and so I'll touch a little on the discussion. Just you can this is coming out. So ideally one suture should be put here at the end of and it's a paramount like watertight closure is of paramount importance, and I'm giving that suture. And so once it is watertight, then your next day you are 100%, almost 100% sure that you are not going to have the shallow AC. And I'm using this technique uh, for more than 20 years, and so giving very good result for me, and I haven't seen any like a shallow AC in my next post-operative. And this is done. Now see, no leak of this. So when you're finishing surgery, the finishing touch should be very now.
Combined surgery may be best suited for a patient with a visually significant cataract with uncontrolled glaucoma despite maximal medical therapy, or patients with significant cataract and mild to moderate glaucomatous optic atrophy, or in patients
I think we can stop here. Move to the discussion.
sutures reduce the risk of
30 seconds,
post-operative
30 seconds.
complications associated with low iop
30
and shallow
seconds.
anterior
You're
chambers.
running behind time.
Sutures may be removed by pulling the exteriorized suture in when intraocular pressure is more than the target intraocular pressure. Post-operative medication is follows. Topical tolbramycin dexamethasone combination 4 times a day for 45 days. Topical moxifloxacin 3 times a day for 7 days.
Thank you so much. I
So,
think I have
Dr.
finished.
Sudhir.
sir, after next talk, we will discuss. Next
No
talk.
issue, sir. No issue, sir. No issue. Hope I have finished in the time.
Yeah, that's why, sir.
Thank you.
Our next talk is by Dr. Rakhi De Cruz. He will be going to present us SICS subluxated cataract. Dr. Rakhi, please.
Hi,
Dr.
sir.
Rakhi,
Yeah,
yeah,
I'm just trying to share my screen.
please, please.
Is my screen visible?
Yes,
Yes,
please.
doctor.
Make it on the slideshow mode.
I'm unable to see my slide here. Okay.
If you can look at the share.
Yeah.
Yeah, now we can.
So first of all, thank you ARC for this great opportunity. So I'll be talking about SACS and subluxated cataracts. As subluxated cataracts always present a serious challenge to every cataract surgeon. Causes of subluxation, as we all know, can be varied, can be traumatic, it can be extreme hypermature malignant cataracts, it can be systemic, it can be syndromic, it can be hereditary, or it can be idiopathic. So today I'll be focusing on the power of SACS in dealing with such scenarios. So when SACS, when we are unsure about the integrity of the CCC that we have made, when there is a large area of sonular dialysis, when it is a dense hard cataract, and as we all know, in phaco, the fluidic motions and the manipulations can increase the area of dialysis and chance of nucleus drop if you are not that experienced. IOP fluctuations are also more during phaco. In SACS, there is always an option to support the nucleus with a second instrument and deliver it safely. So this is not me saying, there is scientific evidence also saying that MSACS is as safe as phaco in almost all type of cataracts. And there's a lot of studies done by Dr. Roger Coyle et al. On SACS in subluxated cataracts, SACS in colobiomatous eyes, and many of the surgeries have been reported to be safe. So once we are planning for SACS and subluxated cataracts, there are certain tips which I would like to give. First is we need an adequately large tunnel because we don't want to struggle with the nucleus delivery. Never deepen the AC too much during any maneuvering. Modified Blumenthal technique with an AC maintainer actually provides a better stabilization of AC, hence used specifically by many surgeons in subluxated cases. And try to make maximally large CCC possible. A good hydrodissection and a hydroprolapse is very much important in these cases because you don't want to struggle with rotating the nucleus. Using two Sinskis or two instruments, one to lift the nucleus from the subluxated side first and other to safely rotate it out. Try to do dry aspiration for cortex removal. Coming to CCC, always start the CCC away from the area of subluxation. Don't extend the CCC when you reach the area of subluxation. Using a microrhexis forceps actually has a minimal stress on the sonules. Need for triamcinolone, whenever we are in doubt that there is a pre-existing presence of vitreous, do a triamcinolone staining. And whenever there is a large area of sonular dialysis and in all cases of traumatic large subluxation, do a triamcinolone staining initially itself and confirm. So there are various stabilizing aids that are provided nowadays, which includes CTR, the CTS, the CONE segment, which can be used varying depending upon the degree of sonular lysis. Capsular hooks are also being very commonly used nowadays when there is greater degree of sonular lysis. So, but there are certain surgeons who just uses iris retractors itself for the capsular support, whereas some others use capsular hooks. So what is the advantage that is being said by the capsular hooks? Since the capsular hooks hook around the equator, it supports both the anterior and posterior capsule. Hence, there is a minimal movement of the sonules and a better stabilization of the PC. So coming to the decision making, it all depends upon what is the pathology. Whether it is a diffuse lysis, if it is a localized lysis, whether it's a progressive lysis like in case of a pseudoexfoliation, or it is static one like in a trauma. So if we have only a localized sonolar dialysis and it is static, you just need to fix the bag itself. For that, you can use either a CTR or a CTS. But when there is a large one and it is progressive, you'll need a double Cioni ring or a double CTS along with a CTR, and you may also need to add the IOL to the sclera. Some protocols that are being followed by many, which include less than 3 clock hours, you can use CTR alone. 3 to 6 clock hours, CTR with CTS segment. Greater than 6 clock hours, CTR with double CTS or double Cioni ring. And coming to the use of CTR in the beginning versus after nucleus removal. Many of the surgeons, especially in SICS, put the CTR in the beginning itself so as to get a good PC support and less amount of iatrogenic sonolar dialysis more. So, but there are certain surgeons who does that after the nucleus removal because they feel like there will be difficulty in cortex aspiration also. In case of posterior capsular rupture, the removal of the CTR will be much difficult. So this is one of the case where they have actually put a CTR in the beginning itself to stabilize just after the rexus. Taking care. So when it is an SS, it's very safe to handle the nucleus and remove it without causing much issues later. So next, there is another video wherein there is a large amount of sonolar dialysis, which was noticed in the beginning itself. So they have put iris SICS actually to stabilize the anterior capsule. Along with that, a CTR is also put, and this is a technique which is known as a bimanual wheeling of the nucleus. Collapse the nucleus. Cyclospatch.
Rakhi, we are unable to hear you.
Can you hear the sound?
Sound is cracking.
Okay. So this is just the last video in which there is a large, more than 6 clock hours of sonolar dialysis. So the surgeon has implanted a CTR along with the CTS. So that's all from my side. I think Dr. Rishi ma'am will be able to provide more insights into this topic.
Yes, we really look forward to her comment.
So, hello, Parakshit. And Raki, a very nice presentation, very nicely illustrated with a lot of animations. Just a couple of points I would like to add. One is that never ever put any of these devices if your rexus is not intact. One. Second is preferably use an injector to put in a CTR, because I have seen many times while putting the CTR, you end up, damaging the remaining zonules. The other thing is, whenever the question whether to put the CTR before or after, you can put it either way, But at times, when you feel that the bag is not stable, it is better to put it beforehand. Only problem is that it becomes sometimes difficult to aspirate the cortex, which gets trapped between the CTR and the cortex. The other thing was that you were showing that the rexus size. Yeah, now the rexus size again, because the zonules are lost, so sometimes it becomes very difficult to make a larger rexus in these patients. But at the same time, if you have a situation, something like a coloboma of the lens, and you try to do a hydrodissection even if your rexus is large, what happens is that this coloboma will prevent the nucleus from rotating. So whenever you have such kind of a situation, it is better that you break the nucleus within the bag. And at times, that's what I say, hybrid phaco is better than just doing a SICS in those kind of cases. And yeah, the last point was you were talking about these the progressive subluxation and the static subluxation. So patients like pseudo exfoliation especially, or patients with hypermature cataracts, chronic uveitis, where you expect that there may be a generalized zonular dehiscence, in those situations beware that these devices may not be of use. You may put in a lens in the bag, but the patient may come back with a dropped lens nucleus, the lens into the vitreous at a later stage. So in those cases, you must fix up the bag either using a CONE. And as far as double CONE is concerned, I don't know, I have stopped using it altogether. Instead of putting a double CONE, I would prefer that one uses a 2 CTS segments which are easy to put, and along with the CTR to expand the bag. So any patient with larger subluxations, progressive subluxations, you should never ever think of just injecting the IL with the CTR alone. So that is all. Thank you so much.
Thank you, ma'am. Thanks.
Thank you, ma'am.
Sure. Sir, on the previous talk, one brief comment by Dr. Amarjeet Singh, sir. Then we move to the next talk. Dr. Amarjeet Singh.
I think we can finish the talks and then ask
Yes,
Dr. Amarjeet Singh sir and Malik sir to give their inputs.
Dr. Purvi ma'am, you sir. Next talk is on topical anesthesia for SICS. Dr. Bimal, please share your screen.
आपका हो लिया मैं चेयरमैन हूँ गाली देने के लिए बस मुझको हाँ नहीं ऐसे करो मुझे नहीं बोलना मुझे तो बाप मानते हैं इसका
Thank you, ASC and Dr. Parikshit sir, for giving me this opportunity. My topic for today is almost topical anesthesia for SICS. Over the years, the technique of SICS has undergone significant changes. We've already established the practicality of SICS in the present times, and it is here to stay. With the quest to give experience and results to SICS patients as similar to phaco as possible, the use of topical anesthesia has seen a rise. It not only enhances the patient's comfort, it also provides an easy and economic technique by reducing the inherent risk of retrobulbar and peribulbar injection. It is especially helpful in patients who are scared of injections. However, it comes with its own set of risks. It calls for patients' cooperation as there is increased ocular motility. It could be painful if the surgery is prolonged, and literature has also reported additional requirement of IV sedation in such cases. So, careful selection of patients is essential for the smooth intraoperative and post-operative course of the surgery. In 2009, an Australian group offered Laninder test to determine the suitability of topical anesthesia for phacoemulsification. However, no such criteria has been suggested for patients undergoing SICS under topical anesthesia. So we decided to undertake a study to assess the suitability of lying down, looking down test for topical anesthesia and compare it with local anesthesia. It was conducted in a district hospital in Maharashtra over 6 months. Patients with uncomplicated cataract who gave consent to be the part of the study were included. Those with complicated cataract, small pupil, congenital developmental cataract, and those who did not complete a month of follow-up were excluded from the study. The patients were screened at different campsites but operated at a common center by a single surgeon. All of them underwent anterior and posterior segment examination with special focus on the grade of cataract and dilatation of the pupil. So in lying down, looking down test, we are looking for three things: the patient's tolerance to the bright light of the torch, tolerance to the examiner's digital pressure on elevating the eyelid, and their ability to maintain eye position in downward gaze. These are not patients, they are just volunteering for representation purpose only. The test is exactly as the name suggests. The light is held close to the face, eyelids are manually separated, and the patient is asked to look down at look at the light and down towards his or her feet for a few seconds. So as you have seen, the first volunteer was not bothered with the light and was able to maintain the eye in downward gaze when asked to do so. So she is a good candidate for topical anesthesia. The second volunteer was squeezing her eye a lot and showed inability to maintain downward gaze on command. So she is not a good candidate for topical and will be posted for local anesthesia. The step is more or less same. I'll just highlight few steps which are different. We put lignocaine jelly 2% 5 minutes before the surgery, and it was thoroughly washed. The conjunctival dissection was as usual. You can ask the patient to look down for better exposure. Gentle cautery was done after putting paracaine eye drops using minimal power. You can use sterile cotton bud or forceps to stabilize the globe while making the incision. You can also put the cotton bud at 6 o'clock to stabilize the globe when you are making the tunnel. Here we are making slightly larger tunnel than usual, which will facilitate easy delivery of the nucleus. Once AC entry is done, we put 2% lignocaine with lingual lactate solution in 1:1 dilution for intracameral anesthesia. Gentle hydro was done, and we used visco expression of the lens to have a minimal handling of the iris. The rest of the steps are same to remove the lens matter and put the IOL. So basically, we were looking for the suitability of the test with secondary objective of post-op inflammation and complication. We used chi-square test and 2x2 contingency table for the statistics part. So total of 250 patients were included. The test was performed. The response to the lying down, looking down test was noted. Those who were negative were posted for local anesthesia, and those who tested positive were posted for topical group. In the topical group, out of 121 patients, 9 did not tolerate topical anesthesia and were given block and posted and shifted to the local group. Both the groups there were no confounding factors as in grade of cataract and pupillary dilatation. We checked the specificity values by 2x2 contingency table. The test showed high specificity of 93.48% and also positive predictive value of 92.56%. As far as complications were concerned, the corneal edema was more seen in the patients with topical anesthesia group. The local anesthesia group had more post-op iritis, and both groups had one case of aphakia. Patel et al. Noted that the light bordered 10% of cases who were operated under topical. So using a light pre-op helped us with the screening of patients. Similar to Wang et al., we also used a combination of topical and intracameral anesthesia. The specificity of our test was similar to that the Figueroa et al. Group found with their Lenin test. However, the patients under topical anesthesia required more time to operate as they needed constant vocal encouragement and instruction during the procedure. There was high incidence of corneal edema in the topical anesthesia group as compared to the local, and we thought because the patient was moving and there might be chances that the nucleus or the instrument may touch during the surgery. However, that edema was not significant visually, and after 6 months, both the group had statistically insignificant result in the visual outcome. So to conclude, the test is a simple and specific objective method of predicting which patients may not tolerate small incision cataract surgery under topical anesthesia. However, the comfort of the patient was documented as a binary response as yes or no, and it was not graded. It was performed only by one surgeon, and both the patient and surgeon here knew about the method of anesthesia used, but the observer who was looking at the complication and post-op inflammation post-operatively was blinded regarding the method of anesthesia. Thank you.
Thank you, Dr. Vimal. Dr. Purvi ma'am, would you please?
Yeah.
comment?
Thank you, Dr. Vimal, for a very lucid presentation. And as you very rightly mentioned and focused on the patient selection, that is something which we all need to keep it as a priority before we decide which anesthesia to use for the patient. Because some patients, they might not actually be experiencing the pain or discomfort, but they are simply so apprehensive that they will not cooperate when you are doing in the OT. And a simple assessment would also be when you do a dilated slit lamp examination and an IO for fundus. So the amount of cooperation that they have on the slit lamp, the way they keep their eyes open, the way they follow your commands to look in different directions, that itself might be a very easy gauge to tell you whether they are likely to cooperate for a topical anesthesia or not. And the second thing is, again, regarding the choice, since the topic is about topical anesthesia, there are different studies, some of which have compared just simple lignocaine drops. Some of them have used jelly, and now we also have intracameral lignocaines. So you can, of course, mix and match and try what works for yourself and for the different set of patients. So, and you should never hesitate to augment. You have started with topical drops, but if you feel during the surgery any step you need to augment with an intracameral, you should not hesitate to augment. And particularly since this is about SICS, I would just like to highlight that one needs to be adept at doing the SICS without use of a superior rectus. Because during topical anesthesia, we are not going to take a superior rectus brittle suture. So you should be comfortable doing an SICS and the nuclear delivery without a brittle suture. And of course, the amount of iris touch, iris manipulation, the nucleus delivery, that needs to be very skilled. So only if you are comfortable doing these steps under a block, then maybe you can consider switching over to a topical anesthesia.
Thank you.
Thank you. Thank you.
Thank you, ma'am. So
move on to our next talk by Dr. Vidmaya Chauhan.
Sir, can I append a few points?
Yes, sir. Yes.
Yeah.
Because for the topical anesthesia, one thing is very important from if you are using your speculum, it should be screwed speculum, number one. Number two,
please let them finish the talk, please.
Okay, sir.
Please let them finish the talk.
Okay.
Yes. Finished. Dr. Kimaya, please.
Okay, am I audible? Yeah.
Yes.
So at the outset, I would like to thank AIOS ARC committee for having me here. So let's talk about simulators today. Okay. So yeah. So for SICS surgery now in the world, we have only Help Me See simulator is available for the particular training. It has virtual reality, haptic feedback, and high fidelity for tactile force and tissue feel. That means you can actually feel the tissue and you can actually see the force what you are giving. It has 3D high resolution visuals and introduced software which can tell you the mistakes what you are doing actually on the simulator itself. So this is how the simulator looks. It has these eyepieces from which you can adjust the refractive error and even IPD. There's a desktop attached to that. The importance of that I will tell you in a minute. So these are the haptics which we use as surgical tools when you operate the procedure on the simulator. This is desktop. This is used for, having whichever step you want to choose, you can choose it from here. And of course, the instruments required for this particular surgical step. And you can see your performance parameters on the same desktop. At the same time, you can review your own video, which you do any attempt on the simulator. So I'll just go ahead and show you some important steps which you do in SICS surgery. So here you can just see the crescent. I'm going ahead with a groove formation. And now here I have shown the crescent in my right hand and the colibri in my left hand. So this is the IOP bar, which suggests you that, you are giving too much of pressure when you're holding the eye. Now crescent, I'm using, and now here I'm going towards left side making lateral tunnel, and here I can tell the student that he has or she has to tilt the short axis and the long axis as well when she's going towards the side of the tunnel, so that he will not have a laceration or the groove on either of the side. Now going ahead with this, now we'll be having right hand in colibri and left hand I'm going to have 15 degrees blade, which I chose from the desktop. Then this training tool actually guides us the orientation of the blade. I'm going correctly inside. So here you can tell the student how much, should be the width of the paracentesis. Now this is visco injection inside the eye, and this depth bar can tell me that actually the depth of the antechamber is increasing. Now this is keratometry. I am having now keratomy in the right hand, and this is the ring on the cornea now. Unless I see this ring, I cannot enter inside. Okay, so you can actually tell that the student has to make the heel up to go inside for the keratometry. So everything you can teach the student. And here on right hand side, you can see the surgeon's hands which are operating, and you can even tell how to handle the instruments here. So this is how the performance parameter looks like, and every step and every particular attempt has such parameters, so the student can understand where he's going wrong. So these are all the parameters which are kept in here. Now here I'm going to show some of the mistakes which we can see on the simulator. So here the student will be going ahead normally, but you can see the depth bar here. He's going first absolutely normal, but then he starts going deep. You can see here on the depth bar here, and then because it's too deep, he actually did premature entry. So this you can actually show in the simulator, and the students can have multiple attempts and make themselves proficient enough. So this is now, this should show you that the student now starts again normally, and then because he has not done his heel down, just see this depth bar, focus on a depth bar. He's going now normally, and because he's going superficially, now he's having yes, buttonholing. So you can actually teach the student what not to do on the simulator. So just one more step for capture axis. So here I have used cystitome as my instrument. You can even have utrata on the simulator. So this is a C-shaped tear has been taken on the capsule. The capsule feels exactly the same as in live. And you can teach the student the movements of the cystitome, how 1 clock hourly he should go, and not to give pressure too much on the lens so that he will end up in ZD, so that you can teach each and every one. And suppose he is not following the exact wound in the iris marking, then he can have tear run out here. These are some more complications you might get when you are doing capsule axis. So this is the performance data. You can see here the size of the capsule, if you have any touch, iris, endothelial touch. So everything is noted on the simulator in the performance parameter. So here I'm showing you the cataract. I'm getting it in the anterior chamber. So we can tell actually how much pressure he has to give for this step. So he has to come towards a little bit towards cornea and not too much pressure downside. If at all he doesn't give enough pressure, if he gives too much of pressure, then what will happen? I will show you. Now suppose you're giving pressure like this, you will have ZDs. So even this is predicted, and the student can improve himself. So this step is also my favorite step. Here I'm doing the vectis delivery, and unless I give counter pressure and move the eyeball towards 6 o'clock, the lens will not come out. So everything is properly, designed in the software. So you can actually teach your students a perfect surgery here. So definitely simulator has its own advantages. You can start teaching from handling of the instruments ahead. Okay, it has real-time alerts, and the most important thing is the trainer and the trainee both are without stress. So which is not the condition in the live surgery. So we have studies to show that it is very important to have less complication and learning curve. So this study shows that students who have done their simulator training before going to OR, they have very less amount of learning curve as compared to students who have not done before. Okay, the simulator training has not been done. So this is one of the studies which shows that the complication rate is 50% less in those who have undergone simulator training first before going to live surgery. And most importantly, the trainee feedback. We have trained almost more than 5,000 trainees in the world now and more than 2,000 in India itself. Okay, so the students tell us that the confidence level of there is too much now, is like very good. They are very confident enough. Of course, the understanding of 3D concepts of surgical steps are good now with them. Then lesser learning curve and definitely proficiency of surgical skills improved. And that's why we have now in the simulator in our Prayogshala, ARS headquarters Delhi. Then we are associated with LVPI and Arvind. They have simulators, and every student first, operates on simulator and then goes to the OT. Even these are the certain centers: Amla, Thrissur, Sankara, Bangalore, SNC, Vijayawada. So these are all centers which are now using simulators before giving the students their live surgeries. So these are some more courses which we have. And first, generally I discuss with all the students the basics of every surgical step, and then we are going to give them the hands-on simulator. So definitely, it goes without saying, simulator is a game changer for cataract surgical training. Thank you so much for the patient hearing.
Thank you, Dr. Kinmaya. Our next speaker is Dr. Kirti. She will be going to tell us about the Arvind way of doing SICS, or what is the practice done at Arvind. Dr. Kirti, please.
Good evening, everyone. Am I audible?
Yes, yes.
So before beginning my talk, I would like to thank AIOS ARC committee, Dr. Parikshit sir and Dr. Haripriya madam for giving me this opportunity to talk. Today, I would like to walk you through the Arvind way for SICS. I am Dr. Kirti from Arvind Eye Hospital, Chennai. One second. The slideshow, I think it was working on while testing, but.
Click on the slide, you should be able to move it.
Okay.
Yes.
So before we go to the technique per se, which we follow in Arvind Eye Hospital, I would just brief about why SICS has become an integrated part of our cataract surgical techniques in Arvind Eye Hospital. Because of its short learning curve that we can easily train the residents, and good accessibility and being cost effective, it can be done easily for high volume surgeries. And also having mastered SICS technique, it becomes a very good stepping stone for phacoemulsification. Also for phaco surgeons who are doing routine phaco cases, if there is any complication, it also acts as a good fallback technique. Once they are confident with SICS technique, they can go back anytime from phaco if there is a major complication or hard nucleuses which need to be delivered through big tunnels. Also, in compared to the olden techniques like ECC, SICS offers early rehabilitation, and with new techniques like shifting the incision sites, we are seeing excellent outcomes as well. So coming to the high volumes, this is the data for last 1 year, where we have operated 27,728 cataracts through SICS in Arvind Eye Hospital, Chennai Center alone. So this speaks that high volumes of surgery can be done with a simple technique like SICS, reducing the cataract burden in the community. And a special mention about the different cataracts like black cataracts, hypermature cataracts, and cataract removal in lens-induced glaucomas are safely performed through SICS, where phacoemulsification would definitely be more technically challenging. So these are there are a few series of videos which would show few techniques which follow routinely in our center. So this is a small pupil with hard cataract. where we go ahead and do multiple minute sphincterotomies to expand the pupil and give a stretch to it while delivering the nucleus. Here you can see the surgeon is performing sphincterotomies with Vannas, which enables an easy delivery of nucleus. This is one more hard cataract where we can prolapse the nucleus with mechanical prolapse. The surgeon is performing a CCC, and after which mechanically the nucleus is prolapsed into AC and then delivered out. And this is a case with the hard brown cataract, which will definitely have a huge nucleus, which is safely prolapsed into AC with the bimanual technique using an IOL dialer, Sinskey hook, and 2 Sinskey hooks. And now the AC is shallowing. The surgeon is injecting a OVD in above and below the nucleus and trying to prolapse the nucleus into AC. So this is one more technique which we consistently follow across all centers of Arvind Eye Hospital, where the nucleus is safely delivered out of AC through the pressure of irrigating vectors. So we can see simultaneously through both videos at how the vectors acts. To end with, we have introduced the square edge PMMA intraocular lenses for SICS surgeries, which has significantly reduced the posterior capsular opacification rates. And we can see the design of the PMMA square edge lenses here. And a special mention about temporal SICS techniques, which we are routinely following in cataracts which have eyes which have astigmatism more than 1.25 diopters against their own astigmatism. With the increased usage of intracameral moxifloxacin, the endophthalmitis rates have significantly come down. So which has led us to shift more and more towards temporal SICS. So thank you for giving me this opportunity once again.
Thank you,
Dr. Kirti.
So last but the most awaited talk by Dr. Parikshit Gupte sir. He will be presenting the Sarans, means whatever the publication says to us, what are the things already published in the peer-reviewed journal. Dr. Parikshit sir, please.
Yeah, thank you, Dr. Deepak. I'll just quickly do it in about 3 or 4 minutes, and then we can have our chairpersons give their comments. I will just share the screen. Please let me know if you can see the screen. Just give me a minute. Can you see the presentation?
Yes, sir. Yes, sir.
Okay, thanks to Dr. Prashant Bhavankoe, Dr. Deepak Mishra for this opportunity. This is a webinar on SICS for all. We know phaco is today the king of cataract surgery, but manual small incision surgery is a royal surgery in its own right. If we look at the 11 studies, which are randomized controlled trials, which have done a head-to-head comparison between phaco and SICS, and we are proud that all of them are from the Indian subcontinent, and one is from Nepal, and the rest all are from India, and they are in some of the most prestigious journals in ophthalmology. And in all these 10 parameters that we compared SICS with phaco, at 618 unaided, when we look at this diamond, if you will see, if this diamond is on this dot line, that means there is no change. So there is not much difference for the 618 cutoff. For the 69 cutoff, corrected, not much difference. But for unaided, if you will see, this diamond is on one side, which means that phaco gives better unaided vision at 69 cutoff. And the reason for is that the astigmatism in phaco is much less than the astigmatism in SICS. This is the only parameter where you can see the diamond is completely on one side of the unity line. Endothelial cell count, both are safe. SICS is safer. We know the time taken is less for SICS. The cost, of course, is less for SICS. So the differentiation is only unaided 6-9 and, of course, astigmatism. So if we look at astigmatism in customized incision cataract surgery, this is a publication by Dr. Boramani, but this is on an individual surgeon's data with a relatively small series. Here, what Dr. Priyanka presented today is that we use pre-existing astigmatism to get the best results. When we do phaco, if the astigmatism is more than 1 diopter, in my practice, I always put toric lenses. All of us, toric lenses today form perhaps 20 to 30% of phaco practice because we don't want astigmatism. And there is astigmatism pre-existing. This Dr. Boramani study here, pre-existing astigmatism is an asset that we use. It is not a liability. So we are able to give better unaided vision without using toric lenses. And of course, that reduces the cost considerably. So, but again, for this, we need studies from more surgeons, more institutions, and stricter inclusion and exclusion criteria as to where it will work. We had again Dr. Nilutparna presenting the 2 mm SICS. Again, this is Dr. Sahu's publication. But again, there are few surgeons, Mumbai, Guwahati, Amritsar, from where we have results. Again, the inclusion and exclusion criteria have to be more specific. What if it is a grade 5 hard cataract? Would we still do 2 mm SICS? What if the pre-existing astigmatism was huge? Would we still do 2 mm SICS? Again, it's done by an expert surgeon and wider applicability still needs to be studied. Again, then this is a trial in which Dr. Moria, Dr. Deepak here are co-authors. It's a large randomized controlled trial, multicentric, on 204 patients with a 1-1 follow-up. And they have said that using continuous BSS for SICS is perhaps as or more effective than using visco-assisted SICS. Now, this is good news because viscoelastic also is expensive. And when we want to do a large number of surgeries one after the other, then we don't need to depend upon visco because the AC maintainer will give us a continuous this of BSS. There is again another study by Dr. Pratyush Ranjan, where the Ranjan SICS marker is a tool that enables SICS to be done under topical anesthesia, which is very precise and safe. And there is a great control on the surgically induced astigmatism. It's Dr. Deepak's publication, but again for this, it's great for expert surgeons, but we need more wider applicability before we can say that this is something that everybody can use. Also, we had Dr. Seth here, Dr. Parsappa talk about smart SICS. This is Dr. Rajiv Raut's one on the laser guided system, the software guided system to reduce pre-existing astigmatism. Now, in customized incision cataract surgery, we were making the incision on the steeper meridian, and the size of the incision varied depending upon how much was the astigmatism. In this software guided system, we are using only superior incision, and yet they are getting 6-9 or almost N6 part unaided vision. But again, it's from a single practice from a very, very experienced surgeon. We also had Dr. Vimal here, who presented his looking down, lying down test, where SICS can be safely done under topical anesthesia. Again, it's a large sample, 250 patients, a randomized trial. And this is something which will make topical anesthesia, or let's say assisted topical anesthesia, more popular with SICS. Because when we look at phaco, the two things that phaco stands out is, one, it does not need an injection, and second, it gives less astigmatism. So if in SICS, we can do the same, not give an injection, and still take control of the astigmatism, well, then it's a win-win situation all the way. This is an Arvind publication where they have shown that cataract with corneal opacity, small incision cataract surgery is much, much more safer than phacoemulsification. And we all know, and there was a debate on this, that SICS is the most popular surgery in Indian residency training programs. ARC studies have shown that. And again, to augment this, because the number of surgeries that today's residents get are much lesser because there are more number of residents and their teachers are more afraid of giving them, because today patient satisfaction is very important even for poor non-paying patients. Again, simulators can be very helpful, and we had Dr. Kimeya Chauhan tell us about it. And I think a lot of training is going to move into simulation. So there are places where SICS definitely has an edge when large astigmatism, black cataracts, poor endothelial counts, very old patients, or as Dr. De Cruz showed, the subluxated lenses and lens-induced glaucomas. So they are both good, phaco and SICS. They are comparable. Each has its own merits and demerits, and it's for us to decide what to do, because we can give excellent vision with whatever technique we choose. Only we have to choose it properly. Thank you.
Thank you, sir. Once again, very crisp and organized talk. Professor Malik, sir.
Malik, sir.
Dr. Singh, sir. Sir.
Can you hear me?
Yes, sir.
Yes, sir. We can hear you, sir.
Do I get the comments about all the topics you have discussed? Yes? Can you hear me or not?
Yes, sir. We can hear you. Please do give your valuable input, sir.
First, I compliment Dr. Bhamakure. I was ARC chairman and I was made needle and defect by leaders of the IOS. But I, fought the IOS all the life. And ARC and SICS I brought on the world map. Number one, 70% of surgery in this country are done by SICS as per data of National Program for Control of Blindness. And I don't take credit for it. Number two, you all people who are interested in doing SICS, I will just speak about your topics and all other things. I would not almost topical. Why should you? Why should you? I do almost topical is I will give subcondylar injection near in front of the superior rectus. And that will cover the area where you make the tunnel. So you don't need any problem. So it will be almost topical, almost topical. But you should not take risk with SICS simply being with the drops. Please, not for me. 2 millimeter incision. If we 2 millimeter outside and inside it become 10 millimeter, then it is definitely not a scientific concept at all. And till first I wanted to use scope, SCOPE. Scope is a American study kind of thing who monitors, and they said that 67% of data or papers or ophthalmology in America are fudged. So please, you are listening or not listening? Can you hear me?
We are all listening to you, sir. You are loud and clear.
So that means that don't go on publication.
He listening, sir.
Don't go on publication. Publications say you so many things, but practical things you experience in life, that your patients, you operated 10 and how happy they were and all that. So SICS, I became advocate when I was practicing phaco very well. And I was impressed by Blumenthal with anterior chamber maintainer concept because of chamber depth and whatever hard cataract you have and all that. So surge is control, everything. So you do phaco, do SICS. So I advocate SICS, the anterior chamber maintainer, for everyone. Subluxated cataract, SICS is much safer than phaco. And Dr. He told you all about Sionis and non-Sionis and all that. He is more expert of that. I am the old one. So toric and wound modulation Boramani is the greatest surgeon of this country who have taught you that you can modulate wound anywhere. Once you see topography where you must put incision, we know basic concept that incision on steep meridian is a principle. But I would never practice temporal incision until incision indicated, because temporal incision is unsafe, takes long time closure, and exposure to infection. So I will prefer superior temporal, inferior temporal, left or right, but superior temporal is the best incision for SICS or even cataract phacosurgery also. And of course, then you can decide your views, as Boramani says, that about the astigmatism, and then you place the incision on the steepest meridian, and that is right. And you go away from, as a principle, as you go away from cornea, your cornea is not affected. Your cornea is less affected if you take a scleral incision, but in sclera you cannot go 8 millimeter behind. You cannot go 6 millimeter behind. So I will say that you can go maximum 2 millimeter behind, so you can have a curve and everything else. Okay. Then next is toric or this and Trabi and SICS is possibly, Dr. Sudhir Singh has told you best, but I do that only simply saying that make a not triangular, quadrangular, big flap, and then make a smaller flap, small kind of a minute one, which Dr. Ruchi taught me, that you can take a one cut, horizontal cut, and they take a kind of a slash of a cornea scleral area. Even if it is a scleral area, I don't mind. I want that better filtration. Then iris props it out. You do the iridectomy, chamber never will collapse. Chamber would not collapse. That is about that. And simulators, it costs more than 1.5 crore. This is for not for my country. Let them do in big centers where they can afford it. But we can manage without simulators. If my teacher or me as a teacher, I taught SICS and FACO, exchanging chairs every time my student doing a mistake. I told one step, he will do one or she will do one. And I say, beta, I will correcting this. And then you come to change the chair. So that motivation to teachers, I cannot infuse, but I would request the teachers should be at least feel that I'll be very proud that people whom I taught, and I'm very proud that KPS Malik's students tell all over the country that this man was helpful without being pompous, without being this one. मैं आंख दिखा देता हूँ कभी कभी, but डांटता भी हूँ ऐसे ही, फिर उसके बाद खाना भी मैं ही खिलाता था सबको. So that's all this one. And that I told in the beginning, now somewhere I just say now, which you would not even agree. ECC, that you do, suppose it in a camp survey, do ECC. I called it minified ECC. That you don't do it 11 millimeter, do it 8 millimeter only, but with a tunnel in the limbus area. Do Raxis, do hydrodissection, take out the nucleus in the anterior chamber, and collapse it out. And if you have to get the infinity sutures, give it. A horizontal suture would not induce the astigmatism. So I taught people when I was working in a small hospital for many years, who came to learn from me. Inka beta, start with extracapsular extraction. FACO is a extracapsular extraction. SIC is a extracapsular extraction. And ECC, which is coming for so many years, then ECC means make a 8 millimeter, learn your axis. The axis learning is a must that we should learn. That if you have a bag, and if bags run away, I teach people that you can make a multiple axis, like a small moon, half moon, like this. And then you can retain the bag. And then AC maintenance, of course, One infinity suture, I told you everywhere if you have longer sutures, infinity sutures is horizontal suture. Vertical suture will induce with the rule astigmatism that you have a myopia on the vertical meridian. If you do it horizontal, it would take care of the left, right, up and down, both. And PG must be trained by dedicated teachers who love teaching and they love students, and the teacher feels that my students will talk about me, that he taught us well. I think that is my kind of a suggestion to all of you. Please,
Thank you, sir.
please. SICS is good, FACO is good, but SICS is a country, even FACO will persist in this country, but FACO becoming universal, it will take 50 years in this country and not required. Not required means I'm not saying I do FACO, but SICS and FACO both must be taught to our PG students. That is my message to every teacher, you and everyone. Thank you so much. Thank you for inviting me. Whenever I was ARC chairman, I was not allowed to do anything, but because of me, ARC on the pedal. Thank you, me. Thank me that I am the one who brought it here. Thank you so much. Thank you. Love you all.
Yeah.
Love you.
Dr. Deepak, if you can summarize, sir.
Thank you, sir. And it's very difficult to have all these SICS stalwarts to bring on the one platform. Me and Parikshit sir tried a lot to take and fix and cover almost each and every aspect of the topic. And Malik sir, Varun Naik sir, Lahane sir, and Sahu sir, we don't have much more experienced people than you all who are the top. So we decided to
our topic to be published in Varun sir when he was a editor. I will salute Varun sir inviting us, me and Ruchi, to put the paper on the SICS with the anti-chamber maintenance. Thanks, Varun. Thanks. Love you.
One thing I would
Thank you,
add,
sir.
Sir is here. Varun sir. Sir, one final
Hello.
comments.
Deepak, can you give me a little chance?
Yes, sir. Yes, sir. Yes, sir.
So basically, it's good, and something like if we are not sticking to the principles of the evidence-based data, Dr. Barun sir has rightly said, then we are just harming this cause. So most of papers I have seen reported as single person, and there is no maybe if you see the appraisal of clinical studies, so there are a set of standards which any study. Nowadays anybody can publish anything, and there are so many other type of. So we need, if this science should be progress, then we should have good evidence that should be univocal to all of us. So
And I
that is
would
my
just say that Arvind. These people are gods for this country. They are the people who do the maximum study, they do maximum patients, and they remain kind of unsung heroes in this country. I salute them. Arvind Hospital System, I salute them.
Very rightly said, sir. They are the pride of India.
This is because of they are sticking to science only. Yeah.
Sir, so these are basically what happens. Most of these advances, or you can say the changes in the astigmatism or the new techniques, they are in the pipeline. Means there is only few studies with a smaller number of subjects has been published. But we think means in the future or any time more when the multicentric study will be done in a big centers like Arvind or Sitapura Hospital, then we can have much more data and we can apply more on the clinical senses. But it's now the change has shift, means nowadays people started doing good publication, as Malik sir said. He and Ruchi ma'am published first when Barun sir was editor. So at that time you can imagine how difficult to publish SICS. But nowadays even these
journals would not, IGO would not accept the SICS papers. before Varun and after Varun. Please. I am not IGO, but they are partial and they publish their own papers, nothing else.
So at the end, I would like to thank all the discussant, mentors, and the presenters for being here. And we were together since from last 2 hours. And hopefully this type of scientific discussions and other thing will help SICS more and more in the future. And again, I would like to thank Parikshit sir for coordinating each and everyone with you. And the whole team of EIS ARC is thankful to all of you. Thank you, sir.
Thank you. Your team, you have done great. Gogte, I love you. That is, you are really scientist also and gentleman also. I am a bit of abuser. Sorry.
Thank you, sir.
Thank you. Yeah, thank you.
बस सर
Thank
सही
you all
बात
the
बोल देते हो,
speakers.
बात तो है ना, आजकल सही बात बोलने वाले कम लोग रहते हैं।
मुझे कौन रोक पाता है?